Good morning, good afternoon, good evening, wherever you are, and welcome to this WHO webinar with the support of TechNet. Today, the subject of our session is Reaching Zero-Dose Children, Insights from 6 Implementation Research Studies. You can listen to this session in English and in French. To do so, please click the globe icon, which is at the bottom of your Zoom window, and you can select French to listen to the interpretation, the live interpretation. I'm going to say that in French very quickly. Vous pouvez écouter cette session en français. Pour ce faire, utilisez l'icône qui est en forme de globe à disposition sur le bas de votre fenêtre Zoom et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. So please tell us who you are and where you're from. You can use the chat to do that. So please introduce yourselves. And you can also use this chat box to let me know if you have any technical support with sound or anything, and I'll do my best to help you. If you have any questions during the presentation, please use the Q&A area. It's available at the bottom of your Zoom window as well. We would like these questions to be centralized on the same place rather than using the chat box. So please help us. And you can ask your questions at any point of the presentation. Our panelists will answer them after the presentation during the Q&A session. Finally, this session is recorded as usual, and we'll share with you the links to the recordings in French and English, as well as the slides by email. I hope you'll enjoy this session, and I'll give the floor to Daniela. Daniela, the floor is yours.
Thank you so much, Alex, and thank you to the TechNet team for helping us put on this webinar today. Good morning, good afternoon, and good evening. My name is Daniela Rodriguez. I'm a scientist at the Alliance for Health Policy and Systems Research, and I have been the technical lead overseeing this work here from Geneva. I am delighted to have our webinar today entitled Reaching Zero-Dose Children, Insights from 6 Implementation Research Studies. And what you will be hearing today is a few snippets of work that's been done under the Mainstream project. So our agenda for today is after a brief introduction of our different speakers, I will introduce you to the Mainstream program. We will have country presentations from 6 different countries where they've conducted this implementation research. And then we'll have some reflections from a policymaker from Malawi, and then we'll have the Q&A and closing remarks. I do want to emphasize, as Alex said, if you have technical difficulties, put the questions in the chat, but if you have questions about the content, please put them in the Q&A feature so we can keep better track. So first, I want to take the opportunity to introduce our fantastic speakers for today. As I said, my name is Daniela Rodriguez, joining you from Geneva at the Alliance for Health Policy and Systems Research. And then with the red boxes are 6 country presenters. We'll do these in alphabetical order, and we'll start off with Boo Collins, who is from Emma Santé in Cameroon. He is a dedicated public health professional and epidemiologist based in Cameroon with extensive experience in infectious disease, immunization, and health systems research. He holds a master's degree in public health and a master's in biomedical sciences. Next, we will hear from Dora Dazi, who is a public health physician and epidemiologist with 14 years of combined experience and currently serving in Ghana's National Malaria Elimination Program as the focal person for research, surveillance, monitoring, evaluation. And there, she provides technical leadership in generating evidence for decision-making and supporting the implementation of national malaria elimination strategies. Then, from Madagascar, we will hear from Sylvester Bemanana. He is a physician by training with degrees in international health, health economics, and social sciences. He has worked as a consultant as well as the former regional coordinator for the USAID Access Program and has led major initiatives in improving clinical skills, immunization, and maternal and child health. From Malawi, we have Ziko Chatata from the Kamuzu University of Health Sciences. He is a well-seasoned and dynamic researcher with experience in monitoring and evaluation systems development, implementation, and building capacity across different development sectors. From Mozambique, we have Dr. Lucia da Costa Vieira de Oliveira. She is a general practitioner with a master's degree in health and a doctoral candidate in international health at the Universidade Nova de Lisboa. She brings over 12 years of experience in scientific research across infectious disease and health systems. She currently serves as the scientific director of the Beta Operational Center in Sofala, Mozambique. Then we will hear from Pakistan from Rutaba Syed. She's the organizational head of the Center for Arts-Based Methodologies and Wellbeing in Pakistan. She's an architect, multimedia artist, and curator, and she's an arts-based methodology expert. Her collective creative practice involves activism for space reclamation, gender equity, climate action, and humanistic design. Our policymaker today is Ms. Jane Zoole. She is a registered nurse midwife, specialized in community health nursing, and has over 8 years of experience in immunization. She currently serves as the Deputy Program Manager for the expanded program on immunization in Malawi's Ministry of Health. And then our closing remarks will be delivered by my colleague here at WHO, Sylvester Malagami. He is the Technical Officer at the Immunization, Vaccines, and Biologicals Department for Coverage and Equity. And he's a global health physician and epidemiologist with extensive experience strengthening immunization systems and reaching zero-dose children in fragile and high-risk settings across Africa and Central Asia. So those are our speakers today. Now I'm going to take a minute to talk to you about the Mainstream Project. Our goal with Mainstream was to support and improve institutionalized learning by mainstreaming embedded implementation research in country immunization programs. It is a partnership between the Alliance for Health Policy and Systems Research, along with the Essential Program in Immunization at the IBB department here at WHO, with generous funding from Gavi, under Gavi's 5.0 zero-dose strategic focus area. Our approach is one that reflects our collective experience, not just of those of us on the call, but those of you who are joining in the audience. Traditional research projects often lead to a research policy gap. And the way that we're working is through local mentor institutes that support embedded implementation by ensuring that findings are not only robust, but they can be translated into clear and actionable recommendations. Those mentor institutes bring together relevant stakeholders to understand their priorities and set a learning agenda locally. And then they support local research teams to conduct that embedded implementation research to generate evidence that can inform policy and program decisions. It's important to note that the Alliance for Health Policy and Systems Research has been working with Gavi and for a long time also with UNICEF since 2015, doing this kind of implementation research to strengthen immunization. So this is building on a long history of experience. Our theory of change that underlies the whole program is that the National Immunization Program is looking to do evidence-informed delivery. And in order to support that, we have the mentor institutes supporting not only primarily institutional capacity, whether it's around research management, research implementation, and stakeholder engagement. And that generates evidence that can strengthen program delivery. And then our overarching goal is to improve program outcomes, and we generate a virtuous cycle of scaled up learning and sustainable learning. Our objectives are going to seem familiar. They're going to be familiar from sort of what you would think of as your typical policy cycle. The first one is around needs assessment, assessing what are the knowledge gaps and priorities regarding immunization coverage and equity based on those stakeholder priorities at the local level. We then enable the integration of learning through embedded implementation research and connecting it to national immunization programs. Then there's scaling of learning by connecting these programs to implemented priorities. And in the long run, we aim to improve the use of evidence to guide policy and program development and improve immunization coverage and equity. The way the process works is the mentor institutes have a convening and mentorship role. They kick off by doing a prioritization exercise where they work with stakeholders to think about what is preventing our achievements in immunization coverage and equity. The Mentor Institute conducted evidence reviews and then hosted an immunization stakeholder prioritization workshop where a series of priorities were identified. The Mentor Institute then issued an open call for proposals for local implementation research teams to tackle those different research priorities. And the Mentor Institute, along with others, then selected the teams competitively. The bulk of the project has been where the Mentor Institutes support the implementation of these projects. So from having protocol development workshops with the teams, doing hand-holding all across implementation, mentorship, and supervision. And lastly, working on a plan of action, reviewing these emergent findings with local stakeholders, and then developing plans jointly for dissemination, communication, and taking recommendations forward. This work would not be possible without the mentor institutes in these 6 different countries. In Cameroon, we worked with the Centre pour le Développement de Bonnes Pratiques en Santé. In Ghana, the Center for Health Policy and Implementation Research at the University of the Health and Allied Sciences was the mentor institute. In Madagascar, it was the Institut National de Santé Publique et Communautaire. In Malawi, the Blantyre Institute for Community Outreach. In Mozambique, l'Institut National de Saúde. And in Pakistan, a partnership between the Aga Khan University and National Institute of Health. And what you will see here is that our mentor institutes include a mix of not just typical academic institutions, but also national public health agencies, as well as research NGOs. One of the things that people are really interested in is what are the different priority topics that have been identified in each of these different countries. And we wanted to talk to you about that process as well as the themes that were identified. The process was relatively standard across the countries. The mentor institutes did an evidence review looking at monitoring data, reports, research, and so on, and then convened a workshop where this evidence was presented and stakeholders then brainstormed on the topics that were impacting coverage and equity. Then the topics were scored, and this varied by country. So in some places, in some workshops, these were scored by individuals or in groups or in a plenary session. And then for all of them, criteria were applied systematically, although the criteria varied by country to be context specific. In order to finalize this, the Mentor Institute organized those priority topics, did some member checking with their stakeholders, and then publicized those topics via the open call for proposals. And you can see here examples. At the top is a table from Mozambique looking at their scoring and their different criteria. The bottom one is from Cameroon. We had 6 different topics that were actually cut across all of the countries. I mean, we have a fairly diverse geographic set of countries here, and all 6 of them hit on these topics in some way, shape, or form. The first was identifying, reaching, and monitoring zero-dose children, which is not surprising. It's the overall focus of Gavi 5.0. The second common topic was around community engagement and communication. The third was around stimulating awareness and demand for vaccines in terms of including addressing hesitancy, misinformation, and distrust. Issues around human resources also came up in common, whether it was supervision of health workers, the distribution, their empowerment, or task shifting. Then also questions about service delivery models, how to integrate or maybe link to primary care. And the last common topic was around data systems, data quality, systems integration, new technologies, and so on. At the same time, each country actually identified different unique topics that were specific to their own contexts. So in Ghana, for example, they identified program funding long-term as a priority topic for them. In Cameroon, they identified local financial contributions for outreach as a priority. Madagascar identified adaptation of vaccine delivery time slots to be more caregiver-friendly, and in fact, we'll be hearing from that project very soon. In Malawi, they prioritized optimizing vaccine delivery in the context of climate change. Mozambique was thinking about integration in terms of their unique topic, thinking about how to align medicine and vaccine distribution to minimize shortages. And in Pakistan, their unique topic was around the impact of the synergies between the expanded program of immunization and the polio eradication strategies. Here are some lovely photos from some of our different workshops that the Mentor Institutes hosted, whether it was priority setting workshops or protocol workshops. And then before I move on to the country teams, I do want to just highlight a little bit of a sort of the depth and breadth of the projects that were supported. So across our 6 different countries, each Mentor Institute supported anywhere between 3 and 7 local implementation research projects. And one of the things that we were very clear on up front is that there are a lot of different priorities at country level, but we have limited time and money. So we're not going to be able to address every single one of those priorities. What you can see here is that in some countries, like in Cameroon, there were projects that lined up with 3 out of 4 priorities, and in others, it was fewer priorities were addressed just by virtue of what was available. I think it's also really important to note that although this work is meant to be taken place hand in hand with the immunization program, we see a variety of different partners actually involved in the implementation research itself, not only NGOs or subnational government officials, but even the National Malaria Elimination Program in Ghana, who we'll be hearing from shortly, and the National AIDS Commission in Malawi. So with that, we're going to turn over to the country implementation research projects. Each of these projects represents one small project of the much larger mainstream effort in each of these countries. And so I want to acknowledge the fact that these are dynamic teams that are, for a lot of them, they're starting out, and for some of them, this may be some of the first work and implementation research that they have done. So with that, we're going to start off with Cameroon. In Cameroon, the Mentor Institute was the Center for Development of Best Practices in Health. I'm not going to try to repeat that in French again. And that team, that Mentor Institute supported 5 implementation research projects. And today we're going to hear from Boo Collins from Emma Sante on the involvement of traditional midwives and community health workers in the promotion of routine vaccination in order to improve vaccine coverage in Kuseri Health District. Over to you, Collins.
Okay, thank you for giving me the floor. Greetings, everyone. Greetings, partners and fellow health advocates. My name is Boo Collins. I'm an epidemiologist based in Cameroon. Okay, so due to internet issue, I'm going to proceed without the camera. I'm here to share the journey and impact of a deeply collaborative initiative undertaken by Masante in Cameroon. The project we are presenting is titled Involvement of Traditional Birth Attendants and Community Health Workers in Promoting Routine Immunization in Kusei District. This will represent months of intense collaboration from June through November 2025, and it embodies a community-centered approach to tackling one of global health's most persistent challenges, reaching zero-dose children. Slide. To truly appreciate the significance of our intervention, we must first understand the context. Cameroon immunization landscape is characterized by significant regional disparities. While national vaccination coverage figures might appear stable on paper, they mask deep inequalities. In regions like far north, where Kusiri district is located, structural barriers such as geographical remoteness, seasonal flooding, high population mobility, and sociocultural hesitancy converge to create pockets of under-vaccination. Our baseline assessment in July 2025 revealed these stark realities. For instance, while some health areas reported coverage above 100% due to population influx, others like Kodoko health area had BCG coverage as low as 52%. These zero-dose children, those who have not received a single dose vaccine, are often invisible to the formal health system. They live in communities where distance, cost, and mistrust create a barrier to access. This was the complex reality we set out to address. Our guiding objective was twofold: to measure increased immunization coverage and systematically reduce the number of zero dose in Kuseri. However, we recognize that simply chasing coverage targets was insufficient. True resilience is built from within. Therefore, our strategy centered on strengthening human capacity at the community level. We thereby sought to empower the existing card of community health workers and traditional birth attendants through targeted training, supportive supervision, and by integrating them into a formalized referral ecosystem. Our hypothesis was that by investing in these trusted local actors, we could foster a community-led model of vaccine promotion that will be both effective in the short term and sustainable in the long term. Right? Our theory of change was translated into a concrete 3-point intervention strategy. First, we built capacity. We designed and delivered a practical training curriculum for 86 community health workers and traditional birth attendants, covering not just the what of vaccination, the schedule and antecedent, but critical how, effective communication, dispelling rumors, and systematic tracking and referral. Secondly, we activated this network These trained agents return to their communities, conducting over 3,000 home visits and focus group discussion, sensitizing more than 5,400 community members. A key innovation was intentionally engaging men in dialogues, addressing a critical decision-making dynamic within household. Thirdly, we establish a clear pathway to care using simple referral slips. Agents identified 180 zero-dose children in communities. Of these, 176, that is 97.8%, were successfully linked to a health facility and received their first vaccine. This process didn't just deliver doses, it repaired and reinforced the critical connection between the home and the health centers. This intensive effort was executed within a focused 5-month timeline. Our journey began in June 2025 with a rigorous baseline assessment to map the landscape and identify our entry point. Throughout July and August, we rolled out training waves and initiated community sensitization. September was the peak of the implementation. We supervised field activities, ongoing data collection. We concluded in October and November with a comprehensive mixed method evaluation comparing post-intervention data with our baseline to capture the full scope of our impact. This disciplined phasing allowed us to learn and adapt in real time. Slide. The data shown tell a compelling story of progress. Let's look at the key outcome, that is vaccination coverage, which saw a positive shift. Pentavalent coverage increased from 104 to 105%, more notably Penta 1. BCG coverage also improved by 2.3% point. While this may seem like modest gain, in the context of a short-term intervention and already high baseline in some areas, they indicate a strengthening of the system ability to reach children. The most direct measure of our success with the hard to reach is the 97.8 of identified zero-dose children were vaccinated. Furthermore, the knowledge and competence of frontline workers were transformed. For example, the proportion of community health workers and traditional birth attendants who could correctly state the number of recommended polio vaccine doses surged from 46% in the baseline to 71% at the end line. This fundamental knowledge is the bedrock of quality advocacy and service delivery. Like, beyond the number, the human impact is profound. Through focus group discussion, we heard directly from the health workers. One community health workers told us that this project made me feel more useful in communities. Women listen to us more now. This speaks to increased respect and self-efficacy. Communities reported greater trust in health facility. We also garnered critical operational lessons. What worked? The participatory training style, the regular supportive supervision that solved problems in real time, and the inclusive approach that brought men into conversation were successes. What were the challenges? The participatory training style, regular supportive supervision that solved problems in real time, and inclusive approach that brought men the conversation were successes. The challenges were logistical constraints like mobility during the rainy season and the need for longer training sessions for deeper skill mastery. Crucially, we operated in dynamic ecosystem. The current Gavi full polio planning initiative in the district created a synergistic environment, amplifying our impact, but also reminding us of the need for even greater program continuation to optimize resources. These lessons are not endpoint, they are the blueprint for our forward. Slide. In conclusion, the mainstream crusade project demonstrated the transformative power of community health system by investing in partnering with local heroes like the community health workers and traditional birth attendants. We can find the missing children, rebuild trust, and move closer to immunization equity. Our journey in Kuseri provides a replicable model for other districts in Cameroon and similar contexts worldwide. We extend our deepest gratitude to communities of Kuseri, our tireless field team, and our partners at Mainstream Cameroon and CGBPS, and to you, our audience. Thank you for your engagement. Thank you.
Thank you so much, Boo Collins, for bringing those lessons from your work in the Kuseri Health District in Cameroon. Next, we're going to hear from one of the implementation research projects in Ghana. In Ghana, as I said, the Center for Health Policy and Implementation Research at the University of Health and Allied Sciences was the Mentor Institute, and they supported 4 different projects across the country. We will be hearing from the National Malaria Elimination Program about addressing barriers to malaria vaccination and seasonal malaria chemoprevention implementation in children under 5 in the Oti region of Ghana. With that, I'll turn it over to Dora Dazi.
Thank you, Daniela. And good afternoon, good evening, good morning. I'll be turning off my video to improve the internet connectivity. Okay. So my name is Dora. I work with the National Malaria Elimination Program as an epidemiologist. On this research, the malaria program collaborated with the EPI to conduct this research that aimed at identifying and addressing implementation barriers to 2 key malaria interventions: the seasonal malaria chemoprevention and the malaria vaccine. Next slide, please. I'll begin with a brief overview of the EPI landscape in Ghana. Ghana's EPI was launched in 1978, and after a successful pilot was scaled up in 1985 to 1991. Currently, we provide vaccines against 16 vaccine-preventable diseases as part of routine immunization. Malaria vaccine is one of these 16 vaccines. Ghana was among the 3 countries to pilot the vaccine, and in 2021, it was officially adopted into routine immunization. The key vaccine delivery strategies employed by the EPI include static services at health facilities through the child welfare clinics, community outreach services, mop-ups, mobile clinics, and then immunization campaigns. Immunization is free at all levels and is provided across all health facilities, including the lowest level, which is the CHIPS compound. Over the years, Ghana has maintained high immunization coverage. Despite these high levels, we still have children who receive no vaccines at all, although this proportion has dropped significantly from 15% in 1993 to 2% in 2022. But then our recent administrative data shows that we still have about 6% of children who have received no vaccines at all as at 2024. And this is an increase from 2023 level. This is quite alarming and signals the need for effort. Next slide, please. Now, onto our project. SMC and the malaria vaccine are 2 key interventions targeting children under 5 years in Ghana. Studies have shown that children who receive both interventions have significantly better protection against malaria than those who receive either one of these interventions. A study was conducted in the Oti region of Ghana. This is one of very few regions implementing both interventions simultaneously. Unfortunately, it's also the region with the highest malaria prevalence among children under 5, suggesting potential gaps in uptake or implementation. So the project aimed to identify and address key barriers and enablers for both interventions using an integrated approach, and then also to measure the effectiveness of the strategies implemented. So in doing this, we measured baseline coverage for SMC and malaria vaccine using WHO cluster LQA survey approach. We also conducted in-depth interviews and focus group discussions with caregivers, community volunteers, community health nurses. We co-designed, and so we identified the barriers, we co-designed interventions with the region and the district, implemented these interventions, and then measured post-intervention outcomes. So based on our baseline findings, we came up with 2 key interventions, which included 1, addressing misconceptions about the side effects of SMC and malaria vaccine. And then what we also did was to incorporate malaria vaccine content into SMC campaign training so that volunteers during these house-to-house visits could identify children who have missed malaria vaccinations, register, and then refer them to the appropriate health facilities for vaccination during the campaign. Next slide, please. So now on some key findings. At baseline, we realized that none of the 3 districts that we sampled met the targets for high coverage, which we defined as no more than 6 missed children out of a sample of 16. Post-intervention, we observed improvement in SMC coverage, but not in malaria vaccination. It is also important to note that the intervention period was quite short, only 3 months, and for current operational reasons, Ghana's policy does not allow children older than 1 year who have never started malaria vaccination to begin the schedule. So if we found a child who was more than 1 year had not received any malaria vaccine, the child was not eligible to start. But if the child had already started, then we could continue the vaccination. On the positive side, we observed significant improvement in integrated messages. Initially, during SMC dosing, volunteers were not providing any information on malaria vaccination or even any of the EPI vaccines. But then after the intervention, when we conducted our survey, more than half of caregivers reported receiving combined education on both SMC and malaria vaccination during the SMC campaign. Initially, it was 0. Post-intervention, it was more than 50%. We also found that 67% reported receiving vaccine-related messages during the dosing. And then also volunteers during the dosing also reviewed immunization records to identify children who had not only missed malaria vaccine, but then other vaccines, and then refer them to the health facilities for immunization. So of 176 children surveyed for the cluster survey, 36 of them were referred for vaccination, not only malaria vaccination, but for any other missed antigens. And then during the campaign, we also introduced some referral registers for children with missed immunizations. And when we reviewed these registers, we saw that the volunteers had referred 101 children in only these 3 districts who had missed malaria vaccine doses. So these children who were eligible were registered, referred, and then vaccination was completed. The key challenge we found, though, was that initially volunteers were just given SMC medicine, and now they had to be given SMC medicine and then reviewing immunization records to identify. So they complained about increased workload, but then this was on a minimal side. And then caregivers also complained about giving too many vaccines and drugs to the children. But like I mentioned earlier, this was also on a minimal side. So in conclusion, our research demonstrated that we could integrate SMC and the malaria vaccination. Thank you. This brings me to the end of my presentation. Next slide. Okay, thank you.
Thank you so much, Dora, and thank you for talking to us about this very interesting project looking at a different new vaccine introduction and how it can be integrated with other services to try to achieve our overarching goals. With that, we're going to hear from Madagascar. Here, the Mentor Institute was the National Institute for Public and Community Health. They supported 7 different projects, 6 of which have a very specific geographic target, and 1 which was nationwide because it was focused on digital systems. Today, we're going to hear from Bemanana Sylvester talking about the acceptability and feasibility of adapting vaccination time slots for parents or guardians of zero-dose children in 2 districts in Madagascar. Please go ahead, Sylvester.
Okay. Okay, thank you very much, Daniela. I'm working for the BHS group, a multidisciplinary group specialized in social research and economic research. It's a pleasure to be here today to present our study on the improvement of vaccination of children with different time slots. Time slots that are more adapted to the community and more flexible. So this project was piloted by the National Institute for Community Health in Madagascar. with a few different partners, financial partners. The presentation we have 4 points. So first, the context of zero-dose children in Madagascar, then our approach to the project and our successes, and then the following steps. So that the sound remains of good quality, if you don't mind, I will switch off my camera. So to start with, in 2024, the DTP3 national coverage was 78%. And despite efforts, Madagascar has still about 500,000 zero-dose children still had at the end of 2024, which represents 11% of children nationwide. Over half of them, over 50% of these children live in the 4 most populated regions in Madagascar, which shows there are some priority zones where we can focus on interventions. Then we identified a few key challenges. The most important one being the time slots, because the time slots are often not compatible with community reality. We have limited community engagement and issues with accessibilities, geographic constraints for some to reach some primary health centers, also very low awareness of immunization benefits. And finally, when we did a workshop on disseminating the results, the person present identified 3 top priority. And they said we needed a different model of prestation that would be more adapted to the reality of the community. So to summarize, to have better access, better time slots, and a community engagement that will allow to reduce significantly the number of zero-dose children. The general objective of our study facilitate the access to vaccination by offering different time slots, more flexible time slots that are adapted to the reality of the community. So in order to reach that, we had an approach, a qualitative approach. And the quantitative approach is to analyze the health center or the health centers. The first results of our study motivated us to go back towards the community to identify alternative time slots that would be realistic. And this approach actually answers to the needs of the zero-dose children and open the access to vaccination to some families that often do not have favorable conditions. It answers to the time slot issue and suggests pragmatic solutions that can be integrated in the current program. This is how we manage something to reach equity, to reach equal access. So to finish, here's a summary of what we managed to do, the different results, the key achievements, what's going to happen next. So first, we collected data in 2 districts, and then we performed operational assessments of the primary health centers, which allowed us to understand the real constraints of the health system and the family expectations. One of the most striking thing was the good acceptability of the time slots, because the adhesion went from 56% to 98%. We also identified the time slots that were most on request, the most requested, so weekends and market days. On this basis, we started a concept of flexible vaccination. Now, challenges, so we still have some issues. The alignment of health worker working hours and the logistical resources. Also, there's a need for clear budget frameworks and occasionally some resistance to change. So next, we are planning for pilot implementation priority district and integrating this model within the EPI operations, and then discussions with the authorities on the scalability and sustainability of this project. If that works, it could open the way for a national model of vaccination that would be more flexible. So this is where we are currently at and where we're going. This is the end of our presentation.
Merci
Thank you very
beaucoup,
much.
Sylvestre. Thank you so
Thank you
much
very
for
much,
presenting this
Sylvester.
work in
Thank you for
Madagascar.
presenting this work in
And with
Madagascar.
that, we are going to turn,
And
we're
on
going
that
to shift
note, I'm
gears
going to turn
back to the mainland in Malawi, where the Mentor Institute, the Blantyre Institute for Community Outreach, supported 3 different projects in different districts in Malawi. And we're going to hear from the Kupeza project that was, which was worked on by the the Kamuzu University of Health Sciences.
Thank you very much, Danielle, for the introduction. It's a pleasure for me to actually present the Kupeza project. The Kupeza project is a local language, Kupeza, which means finding, and in the context, finding the zero-dose children. And this was implemented in Malawi, in particular in Cheu, and we actually implemented together with the EPI within the Ministry of Health. Next slide. So just a bit of context in terms of the zero-dose children in Malawi. Currently, according to the Malawi Demographic Health Survey 2024, the full vaccination coverage has actually declined from 82% in 1992 to about 67% in 2024. And looking at the DPT of children vaccinated DPD. And they are quite difficult to actually find. And this particular project was actually looking at how do we identify the zero-dose children? How do we characterize the zero-dose children? So we do have them, and these actually presents potential immunization gaps, as well as areas which can develop outbreaks. Currently, according to the Malawi Demographic Survey 2024, about 1% of children have not received any vaccine, and that ranges from 0 to about over 11% in Malawi. In particular, in Cheu, where the project was implemented, about 3.6% of children have not received any vaccination. And using the prior work which was done by Mategula 2024, using data from the Malawi Demographic Health Survey 2015-2016, we they mapped in terms of where the zero dose are, looking at predicting the prevalence of that. And we're using that to actually validate the methodology which was used in terms of identifying and characterizing the zero-dose children. Next slide. So the project was implemented in Cheu. You can see from the map, that's the district in gray, shaded gray. The project was aiming to identify and characterize and address the needs of zero-dose children in Malawi using innovative geostatistical methods. And another component was to actually co-design intervention strategies that can be tailored to the needs of zero-dose children in Malawi. We used a mixed method approach, quantitative, using the cross-sectional surveys, and also a qualitative study to identify barriers as well as facilitators, and then also co-design interventions. So we utilized the prior work, as I mentioned, and also used the binomial geostatistical methods to actually predict the zero-dose children prevalence to 1 kilometer square grid. For the qualitative part, we conducted key informant interviews as well as focus group discussions with zero-dose children caregivers, leaders. These included traditional leaders as well as religious leaders and health service providers. And then a co-creation workshop that looked at the barriers, looked at the facilitators, and then develop interventions to address the needs of the zero-dose children. Next. In terms of the achievements, so the study actually revealed that about 1.6 in CHEU percent was the prevalence overall in CHEU, and also that ranged from 1% to 19%. And also the study suggested that age of caregiver above 35 years of age was actually increased the odds of having zero-dose children. Religion was one predictor, as well as not being married was also a predictor of having zero-dose children. I think marriage, being in a union, were actually protective to having zero-dose children. Using the geostatistic modeling, we actually produced high-resolution maps to 1 kilometer square grid to identify the hotspots in the north and south of the district, in this case, the Ncheu district, as you can see on your right. That's the panel predicting the prevalence in Ncheu. And using that approach actually presents a low-cost approach in terms of identifying zero-dose children, because it's difficult to identify where they are. But I think using the methodology that we've used, it's easier to actually, maximize, optimize on the resources, and also, leverage on other interventions that are actually happening. The qualitative component, we've identified barriers to why we have zero-dose children, or why households are not vaccinating their children, which included religious convictions regarding vaccinations, fear of vaccination, vaccine-related side effects, and also just the perceived lack of importance of vaccines. And there are also facilitators in terms of effective communication on vaccine-related information, as well as the religious and traditional leaders' involvement in promotion of vaccines. And what we are looking forward to in the next steps is the dissemination of the results, and working with the district in Ncheu to look at the identified interventions or a pack of interventions, and how to actually implement and develop action plans and integrate these together with the EPI program to implement in Ncheu, and looking at ways of how this can be scaled up to the national level. I think this is my last slide, and I thank you for your attention.
Thank you so much, Zico, for talking us through your work in Malawi in the Ncheu district. Really interesting use of innovative methods. Now we're going to move on to Mozambique, where the Mentor Institute was the National Institute of Health, and they supported 3 projects in different parts of the country. And we'll be hearing about the project on resilience of immunization services in emergency situations, an evaluation of EPI service continuity during natural disasters and outbreaks in Sofala province. So over to you, Dr. Vieira.
Good afternoon. I'm Lucia Vieira. I work in the Sofala Provincial Delegation of the INS, National Institute of Health of Mozambique, and I will present one of the projects entitled Resilience of Immunization Service in Emergency Situation in Sofala Province. I will use my camera. Thank you. This study aimed to analyze the resilience of the expanded program of immunization during the cyclones and the COVID-19 pandemic in Sofala province between 2016 and 2025. Mozambique suffered from different kind of cyclones, like Idai in 2019, Shalan in 2020, and Louise in 2021, which significantly they impacted in health provision and also, or particularly in this vaccination service. The study design was interrupted time series divided in three periods. We have a period before emergence from 2016 and 2008, and the emergency period for 3 years later in 2021 and 2020. 2019 and 2021, and the post-emergency period that was in 2022 and 2025, and in which was considered period post-emergency period. The population study was children age less than 23 months, and for the interviews is another study that we done that was exploratory. The population was health professional, also community leaders in the focal point of Red Lake part. For data source, we use it for quantitative part health information system for data for monitoring and evaluation of Ministry of Health. And also we did in-depth interviews. For data analysis, to a quantitative part, we use a vaccination coverage analysis using interrupted series analysis. And for qualitative, we analysis using content analysis. Next slide, please. For our results, we analyze some vaccines for the National Service of Health, like BCG, rotavirus, measles, polio, pneumonia, hepatitis, and also influenza. We see that the dished line show what will be expected if it doesn't occur those extreme events, and in solid annals we show what happening during those period analysis, the vaccination coverage, and in all vaccine there was a decline of vaccination coverage during the emergency time, and also after the emergency time, and men also did not recover in the post period of emergency. The rotavirus and also DPT3 vaccine show more pronounced statistically significant difference in the period during and also after the cyclones. We can see also in the difference for the percentage that happened for the coverage in the during the emergency and also after the emergency. Next, please. In the qualitative part, we use the capacity defined by WHO to assess the resilience that is measured by to see how was the preparation of the country, also the robustness, the adaptation, and also the recovery. Starting with the preparedness, we showed that it was found a minimal stock of vaccine at the province and also at the district, and was possible to make a communication before the occurrence of the events. This was the positive factors, but also we have a negative factors. That was a lack of resource to implement the contingency plan for those emergency periods, and also lack of awareness of the magnitude of the event, and the NGOs that work in period of emergency have better prepared for the response than the health service. In the robustness, the team was standby to respond to the emergency. The immunization service continued, didn't stop, and the activity was carried out in the coordination with NGOs and also the community representatives. For the negative factors, we have most of the health facility have the damage, their structure. And we had the interruption of the electrical energy and for more than 2 weeks, and also the solar panels was damaged. And we have a logistical limitation for implementing some activities like of transport, fuel, and also the road in the Dosa district was damaged, and we have a flooding. In adaptation, the system carried out massive mobile brigades, vaccination, use of alternative source like nearby the factors with generators, and also long-lasting cold chain. And they took carried out some innovation like vaccination in the residence areas, house-to-house vaccination, and integrated health provision. For the negative factors, we have movement of population to the resettlement, and also considerable number of NGOs. They work temporarily, and we had also insufficient human resource to attend the activity. In recovery, most of the infrastructure was rehabilitated with help with others NGOs, and activities in the national service returned to the normal. The emergency committee was created to respond to the emergency and also the others emergency that can occur. And the system learned from the event, especially in the crisis preparedness. And the negative factors was stock shortage of some vaccines like BCG, pentavalent, and also Retavir. And in the post-emergency period, it can contribute to the failure of reach coverage target for this some vaccines. Next, please. For the conclusion in the recommendation, the expanded program immunization demonstrates stronger preparedness for the COVID-19 for cyclone than for the cyclone or emergence, because they learned with the cyclones how to prepare better those events. And also we ensured to continue the vaccination service during and after the emergency. However, there were some declines in vaccination coverage during those periods, and notably was in the rotavirus vaccine and the DPT3 vaccine. The system adapted and also recovered with the support from NGOs and other governmental sectors, but the system has not yet managed to achieve the vaccination coverage levels similar to the pre-emergency period. For the recommendation, we recommend to continuous training and also capacity building of the manager and the technician in risk of management and logistic and response to the health emergency at different levels, and to strengthen the involvement of the local and the community leaders is a part of response, especially to planning the activities. And thank you. This is our, we present those results in the district that we carry out the study, and also the Ministry of Health today to inform which result we have and how they can better manage the future emergency periods. Thank you.
Thank you so much, Dr. Vieira. And now we're going to hear from a totally different project from Pakistan. Here, the Aga Khan University worked in partnership with the National Institutes of Health as the mentor institutes, and they supported 3 different projects. The one we're going to be hearing about today is very different. It's the only one that was like this across the over 25 projects that we supported with Mainstream. And it was art-based and motivational interviewing approaches to strengthening immunization workforce well-being in Pakistan. And we have with us today Rutaba Syed, who from the Center for Arts-Based Methodologies and Wellbeing. Rutaba, please take it away.
Thank you so much, Daniela. I hope everybody can hear me, but just to save internet, I will close. I'm Rutaba Syed. I am presenting Project Muftari by the Center for Arts-Based Methodologies and Wellbeing in collaboration with our mentor institute, Aga Khan University, based in Karachi, Pakistan. That little green corner you see was our study site, so I'll take the next slide. Yeah. While looking at the context and the long-term struggle of Pakistan with their immunization goals has been, even right now, we have more than 400,000 reported zero-dose children, and our targets are only 70% met by this year. We looked at the barriers with implementation and also like immunization that were kind of a bit holistic rather than more systematic. So we looked at social behavioral factors as well. We also looked at socioeconomic, social cultural factors, which also showcase that the vaccinators' burnout and their willingness to actually go towards solution building is very, very less. And that is very much coming from their own lack of communication skills and their community trust, and also how they are dealing with resistance in super high-risk UCs. Our site was Maliu district. You can take the next slide. So Muftari is also translated as efficacy. And this Project Muftari, is a pilot that strengthens both the emotional and the technical capacity of the vaccinator by addressing not only the vaccinator's burnout, but working through resilience building and tackling vaccine hesitancy through improved trust. Some of our core objectives were to also build social, emotional, and technical capacity of the vaccinator through communication skill development, self-regulatory tools, and also understand the factor of trust versus resistance coming from and through the vaccinator, and how some of the behavioral tools embedded in arts-based and participatory methodologies was implemented across. This project was only 6 months, and we had co-investigators from API program as well as one of our goals. And also this was kind of co-designed as an implementation research, which was focusing towards mixed methods and quasi-experimental design. So 92 government employees were enrolled in this program. 45 were the intervention group and the 47 were control group. And we were able to take this very small group to kind of create a proof of concept as well. So our assessment also looked at how we were not only going to assess their ability to perform well, but their ability to feel better as well, because it's very, very deeply connected. So we looked at their microplan assessment, their attendance rate, and also their rapid household survey, along with self-efficacy, well-being scales, and also their knowledge test for the motivation interviewing. Next slide. So this is a very participatory intervention, and in which basically the day one of the intervention also looked at the validation of the vaccinator, and while the day two looked at how trust versus resistance actually works. And it showcased that whatever story is coming out of the vaccinator on day one, they're able to translate that in their motivational interviewing training, their behavioral tool kit design training as well, how they're able to become trust versus resistance in their own problem landscape. Next slide. So I'd say this is findings and also achievements, kind of step one, that we saw very promising results across the REAIM framework that we were also using as implementation research area for us. So we saw that how the effectiveness also showcased that there was not only increase within the EPI regular updates of their microplan, but there was also increase within their self-esteem scores. So there was 6.8%, which was a very significant increase for their self-esteem scores, which was collected at 2 different data set points, giving them at least a month with the community to engage. Similarly, we saw a reduction in defaulter households by 12%. Comparative to the intervention group and also the control group. With that, we also measured their well-being scales, which showed 7.3% of increase from the baseline to end line, showcasing that this was very significant on their own efficacy. 19% improvement in their motivational interviewing skills as well. And we saw the fact that we were kind of hoping that at best in 6 months, we can increase their attendance by 2%. But to see something significant like 8% increase in vaccinator attendance from baseline to end line among the intervention group was actually very motivating for us, which led to how we were going to envision the implementation and the maintenance of this. So we were able to not only maintain this project in a second round, we also were able to add a factor of community and vaccinator trust belief system with the Gates Foundation in the second round, and also how we can increase the uptake of vaccination as well. We were also able to reach all of the vaccinators in this. Yeah, next slide. Something very interesting that came out of this was also our arts-based data that has developed context-specific challenge map through semiotic analysis. So each painting by the vaccinator while they were doing their challenge mapping, that what happens to them on the field that leads to them not coming back or not doing their job right, or something that kind of leads to these zero dosers not being able to reach. So we saw that each painting and each area showcased a symbolic analysis that we were able to make into a contextualized map that is now being utilized as a problem-solving technique by the EPI. So this becomes, if we do this in each context, this is one of the most scalable and one of the most doable things. Next slide. So some of the just core achievements in with this was also that Mokari generated very rich insights, and also how safe space for a vaccinator was a very dominant factor on how they were able to utilize this training and make it more effective. Similarly, we had the understanding of EPI to view data as very holistic. So it was very creative and very holistic for them to also understand. We were also able to achieve all of the activities in this short time, but that came with another few list of our challenges, which was that this was kind of combining with all of the big catch-up activities. We were also clashing with other timelines, because from state to province, from province to state, it was moving around quite fast. Again, with the vaccinator burnout addressing while another burnout is happening is a very tight space to work with. Some of the next steps which kind of then helped us design the method was also that how can we integrate this into the IPC training when the vaccinator is getting onboarded. So if they have these tools when they are onboarded on teams, that could be really helpful, and we are now looking forward to scale this to provincial and state level. Next slide. The only thing that I would like, because this was a very epidemiology focused area, but done by a lot of mixed method approach. And this was very interesting for us. And I do want to kind of highlight that immunization has to be looked at very holistically at this stage, because we do talk about vaccines do not save lives, vaccination does, and that includes well-being of the vaccinator. And that can be achieved very creatively as well. Thank you.
Thank you very much. And with that, I'm going to stop sharing my screen so that I can bring out Dr. Jane Zole to talk to us from a policymaker perspective. As Ms. Zole comes online, I just wanted to say that I think it's really interesting, the diversity of projects here. We've seen projects that have engaged health workers, whether it's about improving their effectiveness or addressing and identifying the challenges that they're facing in the field, thinking about how do you build partnerships with other entities within the Ministry of Health or the health sector, how do you, or even with NGOs in an emergency context, use of new innovative methods, and thinking about how all of these different things contribute to not only the emergence of not only to children missing doses and continuously missing doses, but also what it is going to take to reach them. So Ms. Zole, if you could turn on your video, we would love to chat with you a little bit about what this means from the policymaker perspective. And if you could talk to us about the implications of integrating this kind of work, implementation research, into the ongoing efforts of yourselves at the EPI program in Malawi, and perhaps reflections from others. Over to you.
Thank you very much, Daniela. So at EPI, we see implementation research not as a separate activity, but as a core mechanism for learning and for adaptation. As a country, we are integrating implementation research by embedding small-scale studies such as Kupeza project, which my colleague Ziko has presented on into our program delivery, EPI. And we intend to use the findings to refine our delivery approach. And we also need to build the capacity of district health teams to conduct and use implementation research to ensure that the evidence that is informs decision at every level. So, of course, we need to start with the districts where we conducted the research and scale out to other districts. We also need to mainstream implementation research into supervisions, activities such as supervisions and review meetings, just to create a culture of continuous improvement that makes immunization services more equitable, efficient, and sustainable. Thank you.
Thank you. And I thought it would be helpful for you to reflect. I mean, this is this idea of the sort of the research and policy gap, and trying to make sure that researchers are working on topics that are important to policymakers and implementers, and there's that relationship there, you know. But I'm not naive to the fact that you guys are, you know, the folks working in the EPI program or at the subnational level at the district management teams, right? You're very busy. You have a lot to do on a regular basis. So what does it take to engage in a project like this, to be able to not only get something out of it, but also put something into it. It's an additional, I imagine it's partly an additional burden. And so it would be really helpful to understand what worked, what didn't work, what could future projects think about.
Indeed, Daniela, engaging with projects like Mainstream is both demanding as well as rewarding at the same time. Demanding in the fact that it requires extra effort, extra time to engage with such projects. As you are aware, EPI program is a very busy program. So adding Mainstream, it requires extra time.
Okay. And then one last question for you about What do you
Ella,
think? Yes,
it's
can you
very
hear me
important,
okay?
and this in the long run helps to improve the services.
Oh, maybe
So overall,
I'm not sure if we'll have to. It's a little choppy.
Yep.
Yeah. I think maybe can you turn off your camera, Jane? You might have an issue with your bandwidth.
Okay. Yes. Yes. I feel a little strange speaking into the void, but I know you're there, Jane. So my last question was
okay.
about, what do you think it's going to take to maintain this kind of engagement and relationship in the long run, right? You've made these connections, but some of what's happened here, some of those connections have been supported by the fact that we have Mainstream and we have BICO working on this. So what do you think from your perspective in EPI it's going to take to be able to sustain this long term?
So to ensure that relevant evidence continues to inform the EPI program, it will take a deliberate mix of efforts. Yeah, so we need institutionalized platforms for dialogue, where we utilize the existing technical working groups so that researchers and policymakers interact, that is regularly, to avoid reliance on ad hoc engagement. We also need funding, and this funding must be sustainable. So this funding will be required by both researchers as well as policymakers. For researchers, they need this funding to produce policy relevance evidence, and for policymakers, we need this for actionable formats. So all these require funding. So we need to allocate dedicated funding for operational research and the evidence translation within the EPI program. One other thing that we need is trust between the researchers and the researchers and policymakers. We need to foster this long-term relationship so that we encourage co-production of research agendas and policymakers feel ownership of the evidence generated. Another thing that we need is feedback. We need feedback to track how evidence is used in policy decisions and provide feedback to the researchers. So, as I mentioned earlier on, this comes back to the institutionalized platforms for dialogue. Thank you very much.
Thank you so much, Jane. And I see that there are some questions that have been coming in through the Q&A, getting responses. I saw there is a question for the Madagascar team. I saw there was a question for the Madagascar team, one for the Pakistan team, and I think in the Cameroon team, there's an open question right now being answered about the use of the binomial geostatistical model to predict zero-dose prevalence. Zico, I see that you've been typing a response. I'm not sure if you want to provide a little bit of a voiceover to your answer.
Yeah, thank you very much, Danielle. Yeah, so Yang, I think thanks so much for the question. So I was just typing, but yes, we had experts in terms of doing the modeling and helping with the data and fitting the models. And I think that was also one part of the objective in terms of capacity strengthening, in terms of use of the geostatistical models, so that with those capacities, then we can also having more experts in terms of the use of this technology or the modeling at district and even I think at national level. So yes, we had experts to actually help in terms of guiding the use as part of the capacity strengthening. Yes, thank you.
Thank you so much, Zico. I see a question for the Cameroon team for Boo Collins. There's someone asking here, households were visited by the project and identified and referred 180 zero-dose children. What about those who have missed or that have an incomplete dose schedule? Did you also identify and refer those kids? And you established a strong tracking and follow-up to that. What extent is that going to be sustainable? Can you? Oh, I think Boo Collins has dropped off. So hopefully we'll be able to, maybe he'll come back in a couple of minutes and we'll be able to answer that. And I am going to take the chair's prerogative and answer the question from Imran Khan about what can be done to integrate immunization within PHC. Very few of the projects talked about this. I just want to say this was, we had over 25 projects, individual small implementation research projects that were carried out across these 6 different countries. And we only were able to give you a small sampling of those. That being said, integration was not a topic that for which we had very many projects. And I think that's in part because there are time and budget limits with these efforts, and exploring how to best integrate, I think felt a little bit daunting to a number of the teams in country. I think one of the things to remember is that there is still a open learning agenda in all of these countries of issues that are facing these the immunization programs in terms of reaching their targets for coverage, their targets for equity, and those remain open questions that not only do the local stakeholders want answered, but that there's implementation researchers out there that are looking to answer those questions. And unfortunately, one of the biggest challenges is often budget. So just to say that on the whole, on average, each of these small projects cost, I would say on average, around $30,000. And I know that is a lot of money in many, many contexts, but it is proportionally a lot less money than other much, much bigger research programs. So in thinking about sort of Jane's comments around funding and kind of investing in operational research long-term, it also helps you think about what's the magnitude of investment that might be required to be able to continually invest in this space. So I see that Collins, I think, is typing it out. There we go. Collins, you're back. So are you able to give a brief response to this question from Eric Osei? Oh no, we lost him again. Okay, so hopefully if Collins comes back, he'll be able to type in his answer. But with that, we are reaching the end of the webinar, and I am going to turn over to my friend and colleague, Sylvester Malagemi from the IVB program here at WHO. And he is going to offer some closing remarks. Sylvester, please go ahead.
Thank you very much, Diana, and colleagues that have spoken. I think it's very, very interesting to hear different views from, Cameroon, Ghana, Madagascar, Malawi, Mozambique, and Pakistan. And I think this is the kind of evidence we need. But I just want to go back. Could you go to it's been very interesting. And we know that recently we just published the IA 2030 midterm review. So I just wanted to point out 1 or 2 things for colleagues on the line. I think it's very important for us to know that, when we talk of zero dose, there are lots of questions, some of them is, what are these zero dose? Where do we find zero dose? So I've tried to actually put out some case definitions for what we mean by zero dose. But of course, we know that also countries also have their own different definitions of zero doses. But at the global level, we think we use DPT as the yardstick in 1 year. So that's fine. And I think all our speakers actually alluded to the fact that, look, they have done 1 or 2 works, identifying who the zero doses are and, and their communities. But I just wanted to point out 2 or 3 things. The first is exactly where are these zero doses? They are actually found in remote rural, urban poor, conflict affected, or gender barrier. And I think the Pakistan colleague mentioned a bit about gender barrier. And I was happy with our colleague that mentioned, things around shifting the immunization session, because it's not just when you say gender barrier, I mean, women might have to go to work, they might have to go to market, and they cannot, the normal working hours does not work for us. So I'm happy that the studies actually touched on all this. But just 3 points to quickly highlight. The first is, for conflict-affected countries, I think this is a very, very low-hanging fruit, Daniela. I think maybe if we have extra funds for such studies, we should actually look at, some 1 or 2 countries that have really conflict-affected teams around it, because we know that although they account for only 24% of the world births, they account for over 50% of the zero dose globally. That's one. And I think the importance of immunization can never be overstated. Immunization is, for every $1 spent on immunization, you save almost $54. I mean, that has been proven. However, I just wanted us to quickly look at the chart I put in place. Although we've done so many researches, we know where we're going to, we know what we need to do. But just to highlight the fact that zero dose has actually increased from 2019 to 2024, when the last result was. In fact, it's increased by as much as 14.3 million zero dose. That's the number of zero dose children we have out there. And I think it's a lot of work. And I'm hoping that some of this, research, some of these ideas that have been floated by our different colleagues can be used to reduce this number of zero doses. That's the first thing I want to quickly say. The second thing I would like to say is that, the zero doses they're not there by chance. We know where they are, and we're continuing to try to identify exactly where they are. These are really, really, it has to do with a lot of equity issues. We know that 47% of these zero doses are most likely to be mothers that did not even attend antenatal. So just mentioning PHC, like the last speaker mentioned, PHC, it's good, but even the mothers might not even be attending the normal facilities that are just even out there. I think another thing, and I'm happy that you mentioned the cost implication of the zero dose case studies. However, we know that in 2026, as we go forward, we're going to have funding constraints, not only at the global level, but for many, many countries, especially as we move towards the Gavi 6.0, and as many more countries move away from, funding the health sector to other sectors within their budget. So I think it's important for us to see how best we can, maximize the impact of these case studies and also of our different interventions. We also know that zero dose communities generate the greatest marginal impact on both health and equity. So I think what I'm trying to say in short is that, look, money spent on zero dose is the best buck for our fund. Next slide, please. So, okay. So I think for us, RS in relation to sustainability, what are the factors that actually contribute to sustainability in terms of how we do our researches? And I'm happy that Jane spoke before me. We need to get EPI managers and staff involved. It's not only us at the global level, the partners. We need subnational colleagues. We need the communities, etc., etc. And again, there's so many things that we need to study. And I think zero dose agenda is just one of many. And I think the onus is on us to actually identify what the priority topics are. We're having outbreaks, we're having conflicts, we're having, different. I'm happy that my colleague in Madagascar mentioned a bit around cyclones. She talked on. So what do we do after each of these different emergencies? Each emergency presents its own different challenge. And I think it's important for us to actually build on the investment that we've made in the RI networks. Next slide. And why are immunization research? I think for me, 30,000 might be big money, but I think it goes a long, long way to answer a lot of our questions. You can imagine if you have an outbreak and you are giving maybe 4 or 5 doses of measles vaccine when you need only 1 dose of measles vaccine to stop the outbreak. You can imagine how much you would have saved, and that is where RIs come into play. So I don't think the benefits of RIs can never be overestimated. It is clear, it is visible, and I think it's important for policy holders to really, really buy into it. I think the most important thing for us is not just about, sending out these results and data. I think it has to do with building national capacity, which is available, but also, interpreting evidence that would improve immunization delivery and uptake. I think at this point, I would like to thank each and every one of us that took their time out of their busy schedule to really, really attend this session. And I want to thank Daniela for really organizing it. Over to you back, Daniela. I really, really appreciate colleagues on the call. And just to add is that I've actually tried to look at some global guidance and tools that countries can use. all what we've discussed are just many things. But if you don't have the home-based records, if you don't have the plans for leaving everyone behind, if you don't have, what to do in terms of coverage and liquid technical resources, we'll be working in the blind. So I would encourage colleagues to really go back to this slide deck, look at the resources that are out there, not just from WHO, but from WHO, Gavi, colleagues from CDC, colleagues from UNICEF. It's a rich document. Please go back. And I think one of the first starting point will be the TechNet platform. Thank you very much.
Thank you, Sylvester, for those closing remarks. I know we're a bit over time. I do want to take the opportunity to acknowledge the support from all of the local country stakeholders that participated in this work, the country research teams, including the mentor institutes that have been supporting all of these teams hand in hand for months and months, the WHO country and regional offices, and most importantly, every single study participant that gave so generously of their time. Mainstream was implemented with technical input from the Alliance for Health Policy and Systems Research and the Essential Program on Immunization here at WHO, with financial support from Gavi, the Vaccine Alliance. In Madagascar, the work was also supported by UNICEF. The Alliance cannot conduct its work without the support from other funders, including the Swedish International Development Cooperation Agency, SIDA, and the Norwegian Agency for Development Cooperation, NORAD. We thank you so much for your time and your attendance today. And we hope you keep an eye out. We will be posting additional information about these projects through our various platforms, and we look forward to hearing from you again. Thank you, and have a nice rest of your year. Goodbye.
Thank you, Daniela, and Happy New Year in advance.
Bye. Thank you.
Bye.
Bye. Thank you.